Good morning. I'm very pleased to welcome you all here to the Transforming Australia's Digital Health Infrastructure information session. I'm Paul Creech, Chief Program Officer at the Australian Digital Health Agency, and I'll be your MC for this morning. Before we get into the detail, I'd just like to acknowledge the traditional custodians of the Ngunnawal lands on which we meet today and pay my respects to elders past and present. I'd also like to extend that respect to Aboriginal and Torres Strait Islander people joining us here this morning. There will be a panel discussion and Q&A later this morning. Given the large number of attendees, the Q&A will be managed through Slido. The Slido details are on the screen behind me. I'm sure most of you are familiar with Slido. To ask a question, go to slido.com and enter the event code 3609-624. Should you have any issues using Slido, there are some agency staff wandering around. Just look for those with the name badge on. This morning's session is being recorded, so I might ask you to smile. The recording and the slides from today's presentations will be made available on the agency website later in the week. But before we get to the Q&A, firstly you will hear from the agency CEO, Ms Amanda Cattermole. Amanda will provide a high-level overview with Peter O'Halloran, our Chief Digital Officer, and his team to dive into the detail. Joanne Greenfield, our Chief Operating Officer, will then follow and link the architecture future state to the agency's annual procurement plan. The panel discussion and Q&A will close this morning, and I expect to have you out the doors by midday. Finally, just some housekeeping. Please ensure phones are on silent. Should you need to take a call, I might ask that you just do it out in the foyer. The toilets are located just on the other side of the foyer in the hallway. And in the unlikely case of an emergency, please just follow the instructions of Hellenic Club staff. Okay, let's get underway. It gives me great pleasure to introduce Australian Digital Health Agency CEO, Ms Amanda Cattermole.
Thanks so much, Paul. Good morning and welcome everyone to our information session about transforming Australia's digital health infrastructure. Thank you all so much for joining us here today, this morning. I'd also like to begin by acknowledging the traditional custodians of the lands that we meet on today, the Ngunnawal people. I pay my respects to their elders past and present and acknowledge and pay deep respect to all Aboriginal and Torres Strait Islander peoples who are joining us today. This morning, the agency team and I would like to discuss with you a transformative vision for our national digital health infrastructure and the part that you might play in helping us deliver it. In this room, we have several hundred people and organisations with the leadership, the vision, the innovation and the technical know-how to help deliver a future where Australians are in control of their own health journeys, where their health information is available when and where they need it, where they enjoy improved health outcomes and the safety, security and trust of a health system that is sustainable well into the future. An opportunity that is as critical as it is exciting. Our intention today is to explain and discuss our vision for a modern, connected, consumer-centred healthcare system and to set the scene for a number of market approaches. You might have seen them outlined in our updated annual agency procurement plan. Now, we're not building the house in one day. This will take time, but many foundations are already in place, including a stable and tested consent-based legislative framework, national healthcare identifiers, and conformance approaches for Australia-wide programs like e-prescribing and My Health Record that enable us not only to drive connectivity, but also to make other improvements to the health system in key areas such as security. We've got the blueprint rolled out on the table, as it were, and we're ready to commence the next stages. Delivering on the National Digital Health Strategy and the National Healthcare Interoperability Plan. Operationalising the policy on sharing pathology and diagnostic imaging data to My Health Record by default. Supporting the HI legislative review led by our colleagues in the Department of Health and Aged Care. These are all part of a broader program to strengthen Medicare and connect it to the entire health system. It is important for us to keep at the absolute front of mind that the policy framework through the Strengthening Medicare agenda is Australians at the centre of their own care. Care that is connected and multidisciplinary teams that are enabled to collaborate to provide the best quality care. How we deliver on this is by uplifting digital systems and capabilities to provide better connections between different parts of the health system and drive better care. Federal Health Minister Mark Butler has described digital health as the single greatest opportunity to transform healthcare in Australia. Against the backdrop of system pressures like workforce challenges and escalating operating costs, we simply cannot sustain, let alone improve our health system without better realising the opportunities that digital health technologies offer for more efficient and connected healthcare. In its paper, Leveraging Digital Technology in Healthcare, the Productivity Commission noted that integrating digital technology into healthcare can save more than $5 billion a year and also ease pressures on the health system. The report also explicitly calls out that both governments and Australians can benefit more from the value of health information by improving information sharing, the very backbone of the National Digital Health Strategy. The Unleashing the Potential of Our Health Workforce Scope of Practice review, currently being led by Professor Mark Cormack, has also recently highlighted that digital enablement is crucial for supporting the health workforce, empowering professionals and multidisciplinary teams to work effectively within their scope and improving patient care. This is our chance to work together and redefine the landscape of healthcare to make it more integrated and more responsive to the needs of those we serve, to reduce rework, drudge and administration and free up time for clinicians to ensure safe, quality patient outcomes, to reduce duplication and complexity, improving sustainability for funders, including, most importantly, out-of-patient costs for patients. In fact, there has never been a better time for us to steward this change. We know that consumers transitioning between primary care, hospitals and aged care face challenges with very real risks of gaps, delays and miscommunication during transitions and the sort of harms that these things can cause. We know that Australians are demanding greater access to their health information at their fingertips, and they are the ones urging their clinicians and their healthcare providers to get on board. We know we need to remove data silos. We don't want people having to retell their stories, and we don't want to burden our healthcare providers with unnecessary administration. We know information flow can only be seamless if we pull together. Coordinated policies, interoperable systems and workflows across different care settings provide consistency and information sharing in a complex environment. As we work together to achieve this vision, we do so with three key goals: driving information sharing by improving access to health information, including sharing by default; improving connectivity and advancing real-time data exchange by better connecting health data across all parts of the system, underpinned by robust national governance and improved technology; and modernising national infrastructure, moving away from legacy systems to a contemporary, structured, data-rich health information ecosystem capable of supporting real-time access to information for the patient and the broader care team anywhere, anytime. These priorities are an integral part of our National Digital Health Strategy and Roadmap. The strategy builds on the progress of the past 5 years and aligns with the government's 10-year national health priorities, including strengthening Medicare and aged care and primary care reforms. Today's discussion will bring together the next phase of work that the agency is undertaking to deliver this vision. This includes setting up the foundational functions of a health information exchange that will facilitate the sharing of information across the health system in a more seamless, user-friendly and accessible way. It includes providing one national harmonised view of all providers that participate in a person's health and care journey across jurisdictions and across care settings, including allied health, pharmacy, aged care and so on. It will enable those providers to search, identify and access individuals in the system securely using existing consent and access controls, providing clinicians relevant information they need to deliver better quality care and to share that information with the whole care team. In addition, the approach the team will walk you through today will not only refresh and distribute national infrastructure by better leveraging existing systems, but give us a reusable pattern that can be drawn upon again and again and again. These foundations will support Australia to better partner with industry and nationally embrace innovations including big data analytics, AI, precision medicine, genomics, and quantum technology. Removing silos and fragmentation and coupling these innovations with regulatory and ethical frameworks will enable us to realise greater system efficiencies, quality improvement and early interventions and move towards a more preventative health system. It will also mean harmonisation of approaches nationally wherever possible, as required by the Intergovernmental Agreement on Digital Health, agreed and co-funded by the Commonwealth and the states and territories. This includes vital work that is being progressed on the legislative and policy positions needed to support the appropriate sharing of health information across all care settings and jurisdictions. In summary, our vision is a connected, multidisciplinary care journey for Australians. Equitable access no matter what part of the health system a person is engaged with. Simplified engagement. And healthcare provided by safe, trusted systems that put Australians firmly at the centre. So now from the what and the why of that vision, I'm going to pass you to other members of the agency team to discuss the how, including what the vision looks like for Australians, clinicians and vendors, the process that is needed to get there, and the pieces of technology that form the essential components of the person-centred system we're looking to build. As Paul said, please take the opportunity to ask questions during the Q&A session using the Slido, and that is going to have a panel of agency staff facilitated by our specialist advisor, Dr. Steve Hambleton. And in doing so, help us to deliver now Australia's health system of the future. Thanks.
Thank you, Amanda. Thank you very much, and thanks to all. I'll remind you again, Slido's there, please use it. We will have a panel at the end, as we've discussed, and we want questions. If we don't get them through them all today, they'll all be answered, and we'll publish the responses, but please use the Slido. It's now my pleasure to introduce our Chief Digital Officer, Peter O'Halloran, Ryan Maven and Nicole Gartrell. Ryan and Nicole are branch managers for architecture and connected care, and they're going to talk to you about the how.
Wonderful. Look. Good morning, everyone, and look, thanks for that, Paul. Amanda, absolutely, it's a journey. We're going to do it one piece at a time, but I would take one exception. I don't think it's a house, it's a home. We all live here. This is all about all of us. So part of that is we are one very small piece of the puzzle, and today it's lovely to see so many of you have braved the Canberra weather to come and join us, and For those of you from interstate, it's a nice, balmy, warm Canberra morning for winter, trust me. Frost wasn't heavy on the car this morning. But it's also important that we're here because we reflect, if I look at the ACT public health system, and those of you who know my history might know I'm a bit biased in this, it's actually the most digitally enabled public health system in the country. If you walk into any of the public hospitals here in Canberra, or you go to any of the 45 community health sites run by ACT government or Justice Health or Alcohol and Drug Services, community nurses, etc. They're all using one single system, one single EMR system that lets the information flow seamlessly from one clinician to the next. And everyone will go, that's nice, everyone has those type of things. Well, the answer is no. Only 2/3 of beds in hospitals in Australia are digital. It's hard to interoperate on paper. But what has actually been achieved here is a system that is making fundamental differences for consumers and clinicians every day. We have seen thousands of adverse medical events avoided by avoiding medication errors. We have seen thousands and thousands of unnecessary blood draws prevented every year because the system can identify that a blood draw has already occurred for that patient that another add-on test can be added to. We've also seen a reduction in the number of scans that a patient might require because the data is moving and is being shared. And finally, if we put all of that together, we're actually seeing improved performance in an emergency department. And that's something in healthcare we don't often see. And if you go back a few months ago, the head of the emergency departments in Canberra was actually in the press talking about what had caused the improvement, and he put it down to putting in the digital systems. So that is a really great thing to celebrate. We are here in the nation's capital where we have amazing digital systems in the public health system. And I used to work for ACT Health. I was involved in all of those things, so you could argue I'm probably biased, and I'd agree. But the challenge is also the second you step foot outside those ACT government-operated facilities, you lose that. And the problem is, those hospitals are great and those community health services are great, and the data is flowing seamlessly, and anyone who's from the ACT here has probably seen some of that if you've been in the hospital system in the last couple of years. But when it goes to get that data to my GP or to get a referral from my GP into the system, it starts to get messy, let alone if I try and see a physio who feels the urge to torture me in the community. It never flows. And that's the real challenge, and that's the challenge for the Australian Digital Health Agency is we recognise the bulk of investment in digital health and a lot of the innovation in digital health to this point in time in Australia has been in the hospital sector. The vast majority of investment is in that sector in terms of digital. What we're aiming to do from some of the discussions today is to talk about the role that we want to fill, which is actually we wish to become the glue that binds all of those individual pieces together, that enables the data to flow seamlessly from my GP into an acute setting to an allied health professional. Heaven forbid at some point in my life I end up in an aged care facility, I need to make it work before I get there, it would flow in there as well. So that's the type of role we see the agency doing. How do we take the innovation and the services that already exist and connect them together? So, very much wanting to be part of the system and the glue that binds it together, we've been talking to lots of people, and over the last year or two, there hasn't been a lot of stuff coming out from the agency about some of the things that we're thinking and the detail behind our thinking. Today is the day when you start to see that. And so we've been talking to a lot of people. Many of you in this room have probably had meetings with me and with the team. And what I would point out is there's three of us on stage here. Ryan and Nicole are here. They're critical parts. They and their teams have been working on this for months, talking to people, evaluating different options, working out how we piece it all together. And it's important that you actually have not just one person behind this, you have an entire agency where we are all focused on delivering what's coming here. And so we've had the forums, formal forums such as the Council for Connected Care and jurisdictional advisory committees, all of those groups where we've been doing deep consultation, discussion about what do people need, what is their priority, what will work for them, what do they want to see. But also with clinicians and with the peak groups, with consumers, and certainly we've done some amazing work with our Healthcare Consumers Forum in Australia and brought consumers into other meetings such as the CCC. We've been focusing heavily with industry, and many of you have put to me your views on what's working, what's broken, and what we can do, and how you can help me with that amazing piece of tech to get that extra mile. And finally, we've been engaging internationally. So we've been looking very deeply and carefully at what's happening around us, what's happening in New Zealand, what's happening in the Middle East in terms of health information exchanges, but also looking at what's happening in other parts of the world where traditionally we may not have looked. So looking at things like the European health data space and talking to a lot of our colleagues in Europe about what they're doing, because they're going on a very similar path, except their path is also a lot more challenging because they're talking about all this legislation crossing borders between all those member states. We've also been working very closely with our colleagues in Health Infoway in Canada and Ontario Health and others, and talking to people in the US about what they're seeing through all the 21st Century Cures Act, and what they're now seeing is they have TEFCA and have all their QHINs to provide that information sharing. And we are bringing all of those learnings to what we're talking about today. And one of the key things we've actually come out of that is really looking at what's happening in the US, which is quite remarkable in some ways and groundbreaking, but also shows the dangers of what we can end up with, where nearly 20% of the data that is now moving around the US health system through these QHINs is actually a duplicate. And so that's a really critical part of the thinking for us to go, what are the good elements we can capture, and what are the pitfalls that others have experienced that we can try and come up with a solution to that pitfall so that we get the benefits that they're seeing, but also get some additional benefits that they're not yet getting. So that's really what we're doing. And today we're talking about reimagining My Health Record. How do we modernise it? How do we actually move it from a monolithic technical stack, a single monolithic tech stack, to a series of microservices? How do we break up this system so in the future we have a series of individual foundational pieces, so something about a repository or an authentication service or an authorisation service? All of those individual microservices that we can plug together, and if you're like me, we all remember the days of tech and plug and play became plug and pray. Very much, how do we put all those pieces together in a different way that suits the needs of My Health Record, but also for a health information exchange, but also things we haven't yet thought about. And Amanda touched on things like AI and quantum, and we'll come to those more, but also genomics, and how do we actually use all those pieces that taxpayers are investing in multiple times, so we deliver that value for taxpayers over and over again, but also we then reduce the innovation cycle so that the next time we're bringing the next solution in to solve the next problem that government presents to us, we already have a series of these services that are plugged together that all of us in this room are building towards and we're all comfortable with. So you already know what the service is for authentication or for authorisation or how the repositories work. You're then just plugging in another piece to a different and new function. So realistically, that's what we're talking about here today. It's fun, it's exciting, and I can't wait. So if we look at what the role of the Digital Health Agency is, you can read all their lovely text about we do services and specifications, and that's correct. Under the PGPA rule, and yes, I'm a public servant, so I'm going to speak in acronyms occasionally, my apologies, fundamentally this is the guiding legislation that establishes the role of the Australian Digital Health Agency. And there are 9 functions put in there for the Digital Health Agency to do. If you look at what we're talking about today, those functions include operating digital health services nationally, having standards and specifications for how those systems operate, but more importantly, how people use those systems and how those standards and specifications are used more broadly across the country. How do we actually then ensure conformance and compliance and measure that compliance? So what we're talking about today are all the core functions in our enabling legislation that was set up by government to specify what the Australian Digital Health Agency should deliver. So what we're focusing in is it's all about our core business. I suppose you could say it's the vibe. What are we delivering that really sets us apart and provides that strong ability to deliver against what government expects? So one of the big things we've been focusing a lot on in the Australian Digital Health Agency in the last year or two is a greatly increased focus on standards. This is really where we are looking, and this is the thing that I think is the #1 game changer from where we've been in the past. We are not different, we are not special, we are not unique in Australia. A lot of what we do is very similar to other healthcare environments and other care settings across the globe. There is always a slight difference and a slight nuance, but that's maybe in the order of 3 to 5%, not 50 or 60 or 70%. So we are focused on adopting international standards with as little customisation as possible for Australia. And look, all the usual suspects you're going to see up there. We have clinical terminology ontology through things such as SNOMED CT and Lowing for pathology and AMT for medicines. We're focused very much on clinical archetypes with OpenAIR and IHE. We're also focusing very much around what we're doing with things like DICOM for imaging formats. And the DICOM format's been around healthcare for a long time. I think almost every one of us in this room has lived, breathed it and had nightmares about it. These are the type of things that we're focusing on. By adopting and using these international standards consistently across the Australian healthcare system, it really enables us to move much faster and make these things work better. So you're going to see the agency continuing to take a greater role in these standards, continuing to work with all of our colleagues across the system, and Sparked is one of those key things that we're going to see works for FHIR. And if you've been living under a rock and don't know what FHIR is, a couple of options. It's vast healthcare interoperable resources. If that makes as little sense to you as it does to me, Google is your friend. But what I would say is FHIR was established and created by an Australian, our very own Graham Grieve, who is a national institution who created it, gifted it to the world. And that's groundbreaking and visionary. And then in Australia, we really did almost nothing to adopt it. That's changing, and that's changing now. And that really, I think, is the crux of where we're going. We are not special. We are simply trying to adopt the standards that we know work, to use them with technologies that we all know are out there and that work today.
Peter, I noticed that there's no ICD on that list.
True, and as the ex-health information manager, you're probably reminding me of a good point. ICD is absolutely not up there. Not because it's not important, it absolutely is, and you'll see the Quality Commission standards are up there in the top right as well. But ICD is one of those core things we use for clinical coding in Australia. But the work we're doing is also with SNOMED International to actually have a mapping between SNOMED, CT, and ICD. And so part of the focus we're also looking at is how do we help solve some of those workforce shortages in the system at the moment. In clinical coding, it's a massive shortage globally, but particularly here in Australia. And we're working with SNOMED International and WHO to make sure there's a mapping between SNOMED CT and ICD.
Wonderful.
Knew I wouldn't get away without that one. This is the downside. I normally put my staff on the spot and promise things while I'm speaking. Now they're going to do the same to me. Gotta love it. Karma's a wonderful thing. But when we're doing all this, it's really critical to mention this is not an ICT transformation. Yes, I'm the Chief Digital Officer. This is not being driven as an ICT project. This is a clinical transformation. We are talking about transforming the services that are provided to support the provision of exceptional clinical care that's designed around a consumer. And so everything we are doing is based around a lens of clinical governance. And if you haven't yet seen it, the agency's clinical governance framework, it's available on our website, you can find it now in a couple of seconds, sets out a framework of how we actually operate and how we drive everything. And we're really using our clinical governance focus to ensure that the services and the specifications that we develop are high quality and safe to use. Because that's a critical thing. We need to remember this is people's lives we are talking about here. Our chief clinical advisors and our digital health advisors have been amazing in this and will continue to be, and I'm guessing you might feel a bit of that flavour as we keep going, of our focus around this. But I would emphasise, once again, this is a clinical transformation, it is not an ICT transformation. Security is something we always talk about, and recent events in the last 6-12 months would have people talk about it more than we've ever talked about it before. What I would say is a couple of things. One, we are talking about security by design. We are baking in security from the ground up with everything we are doing. And I would argue we can do more, and we are, but also the broader sector can do more in cybersecurity. And I'd say it is incumbent on every single one of us in this sector and in this room to do more around cybersecurity. And we are focusing on that as we're doing the modernisation, and we'll be looking to partners in industry as we continue this modernisation for how you can bring new and different ideas to how we can actually provide that proper IT cyber protection to our services. Very much we're focused around the CIA triad for information security.
Can you help me out, Peter? Can you tell me what the CIA triad is?
Well, look, you could assume it's the Americans and, I don't know, some Creole gang, but otherwise, CIA triad is something that if you're doing healthcare IT, we all do out of just natural, the way we operate, but we don't think about it. And so confidentiality, how do we protect that data from unauthorised access? So only those who are authorised to see it get access to it, and that really, I think we'll talk about that a bit more in a moment. Secondly, it's around integrity. How do we ensure that the clinicians and the consumers can always rely on that data to be accurate and complete? And the final bit is about availability. There's no point having data that's appropriately secured and that's highly accurate if you can't get to it at the point of care when it's necessary. So everything we're designing is designed around those three competing interests. And that really is critical because that is how we're designing the systems from the ground up and the services. But enough of that, what does it actually mean for real human beings? Fundamentally, if you're a healthcare consumer, you're at the centre. You're at the centre of our design, of our thinking, and of the reason why we provide these services. The consumer is at the centre. You have control. Control of who has access to your data, and also you have control of your own health conditions. You are not going to be subject in the future to not being part of the information flow from one clinical professional to another. You will be in the middle and you will see it, and at times you'll have ability to control it as well. So you really are becoming the centre of the universe, as a consumer should be, for this information and these services. Fundamentally, the idea is anywhere, anytime, and all of your information is just available to you in the palm of your hand. You get to choose how and where that is shared. You don't have to think about it. It just works. And I don't know about anyone else in this room, but I don't wake up in the morning and think, oh, today's my day, I'm going to do personal admin, I'm going to focus on my healthcare. I probably should do something like that. My wife would be happy. But fundamentally, we want to take that burden off consumers. So you go to one place, in one app, in the My Health app, where you can find all of the information you need, have access to all the services you need, get a prescription, report an adverse drug event, get your next appointment, whatever it is you need, see all of your data, control who has access to it in one place so you can get on with your life.
But Peter, what if I don't want to use the My Health app?
Well, I'm not quite sure why you're on stage with me then, but fundamentally, in all seriousness though, we recognise that many of us might want to have access to this data on our phone. Other people don't really want to know it and trust their clinical team to provide that exceptional care without them seeing all the details, and that's equally fine. We are designing the systems and the infrastructure so that if you don't want to interact with it, your clinicians still can and that data will still flow. But we're also designing it so that if fundamentally a consumer does not want to use the My Health app, but they want to use another third-party app from a not-for-profit or their drug company or a jurisdiction or someone else like that, they can. And we're actually making the list of all the APIs that we develop for My Health app available on our developer portal so that anyone else can go, I want to actually provide a service that pulls together this great data, and that great data might be for a specific condition that we could never support nationally, but a smaller group can, and we'll make those APIs available. And subject to people, those vendors going through the approval processes, become a registered portal operator and ticking off all the boxes, they can. So it is all about choice. It's all about giving people multiple options of how to engage with it, because what we want to do is have all of those regulatory controls and all those policy parameters and all of the identification centralised, but who does it, which piece of the puzzle, we're providing options. But let's take a little scenario. So imagine you're me, let's say it's, I don't know, last night. I'm feeling a bit of tightness in my chest. Is it because I had a bad curry, or I don't know, could be something happening today? Who knows? So I pick up the phone, call the amazing team at Health Direct, and have a quick conversation. And obviously the triage nurse on the end of the phone is probably far more polite and used to dealing with numpties like me, and will say, yeah, Mr. O'Halloran, if you've got a tightness in the chest, you might want to think about actually calling an ambulance or going to emergency rather than calling a non-essential, sort of a non-emergency helpline such as Health Direct. And she'd be right, or he'd be right. And so I hang up the phone, I call 000. Very simple thing. 000 call centre operator, I go through basic details, a paramedic crew is dispatched to my house. At the same time, I'm still on the phone with the call taker and talking through other elements, and the call taker can actually see and will have access to my health record and can see my recent allergies and medications, any diagnoses, hospitalisations when I've been to see my GP, and can also see, because I trust clinicians in Australia, that I've shared my data through my health record with anyone that accesses my record. They can all see it. And then I've got a smartwatch on my wrist that's linked to my phone, which is automatically uploading to my health record in real time. And the call taker can see, well, actually, you've done a few one-lead ECGs on your smartwatch before, so ask me, can you do it now? I can do that. Within 2 minutes, that data is available in my health record. So while the paramedic crew is still on their way to me in the truck, the call taker has actually now suddenly got that. The data's come through and elevated the level of the priority of that call. And so suddenly I've now got a couple of crews on their way to me, or even a fire truck sometimes. And that type of thing is then on the way, that call taker can then brief the crews on the road what they're walking into, and they've got the same access in the ambulance to that information before they get to the job, so they're not walking in as blind as they normally would be. Of course, they turn up, I get in the back of the ambulance, stop misbehaving and do all the right things I'm supposed to do. They'll provide treatment, take notes on the way. I turn up at the hospital a few minutes later. All of the notes that they've taken and any readings from a proper ECG rather than a simple one lead one on my watch are then uploaded and shared with the hospital in real time. At the same time that I'm being wheeled through the door on the trolley, the data is flowing seamlessly from VACUS, the system they use in ambulances, say here in Canberra, straight into the digital health record, the EMR system used in Canberra Hospital. And all that data flows through in real time as I'm being wheeled in the door. The triage team at Canberra Hospital can see all the data about me on the spot. This is the vision of what we're aiming for. This is where we are looking at going, and this is what it means for a consumer. You don't think about it, it just happens, the data flows, and it lets clinicians get on with actually providing exceptional care rather than the constant battle they have at the moment of trying to tie data together from multiple disparate systems. But I'm guessing, whilst we're all consumers, there aren't a huge number of consumers in a formal capacity in the room today, so what does it mean for clinicians? Once again, it's about reimagining how you get access to that data. So subject to patient consent, very simply, you get access to the right information at the right time so you can provide that exceptional care. The idea being very simple. We move away from the lovely sort of PDF CDA style that we all love to hate. We move to atomic data in context in your own clinical information system. And this is a key part. The medications, the allergies, the diagnoses, the results, all of that displayed in context in your existing clinical information system. Gone are the days when we should expect clinicians to have to log into yet another system, yet another portal to access this data. It should be in the system they use now to provide the clinical care that they have now. And people say, oh, that's not possible. Well, we already know in Australia there's at least one general practice system that's doing this today. If I look at big EMR vendors that are in Australia but also have a presence overseas, they're doing it in other jurisdictions now. So we know it's technically very possible. It should be seamless and people shouldn't have to think about it. The data should just flow. And fundamentally, it's about providing a single source of truth. Providing that core record for a consumer that a clinician who's providing that care can rely on and trust, that it's complete and accurate and is actually about the patient in front of them. But it's also about using some of the things like the directory, which should be one of the first phases of the National Health Information Exchange, to see similar information about the details of all clinicians and providers in the country across all care settings. So when a clinician is referring someone to another clinician, they can see that data. They can have it all at their fingertips rather than having to spend a lot of time going to find it and bring it together. That really is where we're going.
Peter, that all sounds really exciting, but what does that mean for HIPS?
Well, for those of you who don't know HIPS, and no Dorothy Dix's set up here at all, HIPS is one of the products that the agency provides now and has for many years that is in two parts. One, it's middleware that lets people connect to My Health Record, whether they be pathology or diagnostic imaging sites or pretty much all hospitals in Australia bar one state, that lets them share all that data with My Health Record, access the health identifier service and so forth. As we go through modernising, and I'm hoping you're going to touch on this, Ryan, in about 5 or 10 minutes, if not you are now, we're going to make those connectors actually work. So you won't need the middleware that HIPS provides anymore. Fundamentally, we need to reimagine how those connectors work so it's easy and simple, that removes the need for HIPS and all the infrastructure that individual jurisdictions and health services then have to run on their own kit to operate. The other part of HIPS is the viewer, which is something that majority of clinicians in hospitals use now to actually access My Health Record. They don't think about it, it's generally there in context, it just happens and it pops up, which is good. But it's not great. The vision we want is it should be native integration, so when they bring up the page that talks about allergies in their clinical system, it displays all of those allergies, not just ones that they've entered or their colleagues have entered, but also those sourced from national infrastructure. That means that really the viewer part of HIPS will only be necessary in the future if either the software vendor for the software that that site uses has not updated their system to comply with best practice, or alternatively, the system might have gone down. So there's a role for HIPS into the future. Long term, however, the role for HIPS is greatly reduced from where it is today, not because we don't love the product, because we do, and we're about to release an updated version that if you use HIPS, upgrade to version 8.3.1, because I guarantee it's going to be a life changer, but because there are even better ways of doing it. And the answer is the agency is not always the solution to those problems. So that's really where we're focusing the future of HIPS. But while we're talking about HIPS, what does it mean for software vendors? And look, there's so many of you in the room today, and I'm looking out at a sea of very familiar faces, so my apologies if you've heard me talk about this before. But fundamentally for software vendors, it's a really simple concept. We want you to build it once. Build to one set of requirements in Australia, not 57. Build it in a way that is internationally consistent with the standards, which means if you're an Australian company and you're actually developing to all these standards in Australia, it then opens up further markets for you very easily to export the amazing innovation that you're doing here to other countries that are using the same standards. It also means if you're bringing in software from overseas, if it's already compliant with those standards overseas, then you know with a tiny bit of customisation in Australia, it will work here. And that's a really key thing we're doing for software vendors. Fundamentally, it means for you, and yes, there'll be a lot of re-architecting involved, but let's be honest, watching how many of you are already involved with the Spark Fire Accelerator, you're already doing that now. By sticking to international standards, it really does open up opportunities for everyone. But what it really also does say is everything you've heard so far, and in fact, the far more exciting stuff you're about to hear from these two amazing people next to me, is that innovation is at the core of everything we are now doing. We need you. We cannot do this on our own, and we don't want to do it on our own. So we will have a whole lot of other things we're doing, and there's some good news coming for software vendors and a whole lot more work coming for all of you, I'm sure. But fundamentally, what I would say is that journey starts today. Today is the beginning of the new world.
Peter, I might interject there and suggest we have already started.
Really?
A mere 2 weeks ago, we released the Digital Health Standards Catalogue, a resource that can be used by anyone to access, in one place, digital health standards and specifications. We're going to build this out to be a living, breathing tool that can comprehensively give you a point of access to know which standards you need to uplift your systems. A big thank you to the Standards Advisory Group who helped us to get to this point today. It was a busy week that week because we also delivered the procurement guidelines. We've started with 3 systems: electronic medical records, laboratory information systems, and electronic chart systems. But we intend to cover any system that you intend to procure in the health sector. The guidelines will give you an opportunity to see what standards are relevant for national infrastructure, but also what you would need to build your systems to, or what you would need to purchase to make sure you have a very clinically safe, secure, and nationally conformant system.
So does this mean if I'm going out to buy a new EMR, if I'm not working with the agency, I've decided to move on to something else, I just go to this website and I can cut and paste all of my requirements for all these standards?
That is the intention, yes.
So if I do that, the software vendors are then hopefully building to that software because they've also seen these guidelines and it's easier and quicker for them to respond to my tender.
Absolutely. It provides transparency to the tendering process. You can also make sure that you're staying competitive in the market.
I love it.
We've recently also delivered the National Healthcare Interoperability Plan. This plan, in collaboration with Services Australia and the Department of Health and Aged Care, intends to increase the adoption of healthcare identifiers nationally. We believe this is one of the linchpins to connected care and to ensuring that information can flow throughout the system. Every software system should have the capacity and the ability to record a patient's identifier, a provider's identifier, and an organisational identifier. Oh, apologies, I've gone too far. Now, you would have heard Peter saying a little bit earlier that we have a strategic vision to implement FHIR. We recognise that we need to uplift the workforce capability and skill set in this area. Some of you in the room today may have attended one of our FHIR training courses that have been delivered by the University of Melbourne, HL7 Australia, and the CSIRO as our partners. In fact, we have trained over 680 people nationwide in FHIR, and we have no intention to stop. We'll be releasing some new courses shortly, and we'll be opening up for more people to be trained. This is how we achieve our fiery vision. And to add spark to that fire, we also need to acknowledge, I had to do it. We also need to acknowledge the Sparked Accelerator, which is working, in the collaboration with the CSIRO, HL7 Australia and the Department of Health and Aged Care and the agency. It's a community collaborative looking at designing the minimum core data sets that we need to capture at the point of care, but also to facilitate meaningful data sharing. They've just released the AUCDI Release 1 with a corresponding FHIR implementation guide. I encourage you to have a look at it. It's fantastic work. Now, it would be remiss of me to talk to you about all these wonderful things we've been delivering without talking about our most recent delivery, which is the Conformance Framework. Published last Friday, the Conformance Framework is part of core business of the agency. It is a fundamental activity that we do, and this framework reimagines how we do it. The Strengthening Medicare Task Force suggested that it was very important we would have clinically safe and secure systems. The framework and our conformance and assurance services is how we ensure we can deliver on that. We are looking forward to redesigning conformance to make it work for you. Now, we do acknowledge, and we have heard you, that the current connection and conformance process is cumbersome. It can take up to 12 months for a software vendor to connect to national infrastructure. We would love to change that. And as to change that, we have set up a program called Streamlining, Conformance and Connections. It'll look at removing the administrative burden, it'll look at removing some of the challenges, and it will look to streamline the entire process. We want to make sure that we can reduce the time it takes to connect to national infrastructure from 12 months down to 3.
And look, that's great, Nicole. I'm glad to hear we're finally fixing it. But 3 months still seems like a long time to me. Why can't it be a month?
1 month? Tell him he's dreaming. Although, as we start to talk about the modernisation of the My Health Records system and the Health Information Exchange, maybe that 1 month could be achievable. That does beg the question, though, what is the Health Information Exchange? So, the Health Information Exchange is really around bringing together all of the systems and the silos of information across the whole health system, and to unlock that information to enable appropriate clinical care and to really enable those better health outcomes for consumers through secure transformation and transferring of information between settings. It's more than just building up services and products in the national infrastructure. It's really around applying those consistent frameworks, standards, models, patterns at each of the conformant connected areas across the Health Information Exchange. So no matter where you are in the health system, having the same ways for sharing information, discovering information, and working together. HIE is really around making that health information available. And as we've talked about before, this isn't about technology, it's about clinical change, it's about patient outcomes and what we can do in this space, and the microservices approach that we can apply to enable the innovation to deliver on that promise. Now, to understand what we're talking about with Health Information Exchange, we can think about a brief example where we will look at a patient arriving at a hospital or an emergency department. They know that they've had some medical imaging done recently. They know that they are on some medications, but they weren't able to articulate to the staff at the hospital the details of those services or the information around that. So what we see here is that the staff at the hospital can use their electronic medical records system without having to know they're actually using the Health Information Exchange to initiate a request for information about this patient. So we know who the patient is, and we know who is operating the electronic medical record because that's the person who's actually logged into the system. So what we see here is the electronic medical record in that setting triggering a request into the Health Information Exchange. Now, what we see with that first request is the provider, so the health identifiers, the national health identifiers for the provider and for the consumer in this case, being passed through with that request for information. And that enables the national infrastructure to then use that consolidated source of provider information that we've referred to authenticate this provider and verify that they are an appropriate person to be accessing information within the Health Information Exchange. We are then able to also authorise or verify that the provider is appropriately accessing information for this consumer. Has the consumer put in any blocks against this provider from accessing their record? Now, for the case of this example, we'll assume that there's nothing in place and it is appropriate for this provider to access this information. And this is where the Health Information Exchange actually goes out and discovers the information across the ecosystem. Now, there'll be information that the HIE already knows about, but we're verifying that information is still there and discovering whatever else is there. So it's about what we know and what we don't know about this patient. Once we've found that information, we can then report back the electronic location of that information to the requester. So we're not talking physical addresses, we're talking internet addresses or endpoints that the electronic medical records system can use to then go and retrieve that information as appropriate. So the request that comes back from the national infrastructure in this space is everything that the electronic medical record needs to be able to do what it does with the indisputable proof of identity, the computable authority, which can be picked up by any other system across the Health Information Exchange, and, as I mentioned earlier, the electronic locations of that information so it can be retrieved as needed to deliver clinical care. And again, as we've talked about before, this doesn't pop up in a separate window or a separate app. This is appearing within the electronic medical record, so it's part of the care process, not an extra bolt-on that sits on the side. Now, we've talked a little bit around what this means. Once we start scratching the surface, we start getting very technical. We start talking APIs and microservices, authentication and authorization, OAuth, tokens, and I appreciate that's not language that we all speak. So to raise this up a level and to make it more relatable for the vast majority of us, we've introduced the concept of interoperability patterns. And what we're talking about here is grouping up all of those complex transactions into more commonly understandable patterns that are repeatable and reused all across the Health Information Exchange. We'll just talk through those briefly. Firstly, we have the Discovered Information Exchange pattern. This is what we just talked through. This is where anyone connected to the Health Information Exchange can request information around a patient or a provider or a service, and the Health Information Exchange will discover and provide that information back to the services so they can use it in context. So hopefully that all makes sense. The next pattern that we can talk to is the Directed Information Exchange. So this is where information passes between one party and another with an expectation that some sort of action will be performed, be that taking an appointment for a follow-up.
Ryan, what does that mean for a consumer? Does that mean I can send something directly to somebody?
That's a really good question. And that leads us on to the next information pattern, or interoperability pattern, being the consumer-mediated exchange. Now, with this pattern, we're really empowering consumers and putting them in the middle of the information flow through the Health Information Exchange. Here we're talking about the referral to a physiotherapist going to the consumer before it goes to that provider, and the consumer being able to say, actually, I know the GP has referred me to this provider, but there's a physiotherapist that's next door to me. They bulk bill. They know my needs really well. I've worked with them before. I'm going to direct my referral to them instead. Or, like we see with e-prescribing at the moment, you could route your prescriptions through to your appropriate pharmacy and know that they have your needs covered.
So it's really all about embedding consumer choice from the policy perspective into the actual technical solutions.
Absolutely. Consumer empowerment is at the heart of the Health Information Exchange. Moving on, so we have the information publish pattern. Now, this is something we're probably quite familiar with. The places at which information is created can publish that information, and we see this pattern today with the My Health record, with documents being pushed up. Where we see this pivot with the Health Information Exchange is that the information can stay in the location that it was captured. And what we're publishing is the fact that there's information here in this location that can be discovered by anyone who's looking for it when they need it. So that's really how this applies and how this steps up a different level for the Health Information Exchange. The last pattern is the lifecycle management, and it's a little bit hard to understand here, but really we're talking about updating existing records that have already been published out to the Health Information Exchange.
So it might help to think of this like a lab result that comes in as an interim and then is published as a final.
Absolutely, yes. And that's probably one of the most high use cases that we see for the Health Information Exchange with pathology results updating, because every pathology result we see come through goes through that same cycle. And that is a good example, seeing that incremental update of status on those records. All right, so now that we've talked through the interoperability patterns and we've got an understanding of how they're applied across the health ecosystem, let's take a closer look at what happens actually inside the national infrastructure when we're looking at how the Health Information Exchange works. So we'll zoom in and we'll take the top off and look at what's on the inside.
Don't take tops off.
All right, so what we see here on screen now, we have the current repository for My Health record information primarily based on CDA technology. We have our orchestration and business logic layer that sits in the middle, so two platforms that are providing the MyHealth Record capability today. On top of that, we have MyHealth Record portals, we have the MyHealth app, and this really gives us what we have as a stack of technology right now for supporting the MyHealth Record, in addition to all of the policies and frameworks that make this available. Now, what we need to do moving forward with the modernisation of the MyHealth Record is to reinvent that repository layer with a FHIR native and empowered platform. So shifting away from older ways of managing information to the FHIR supported models, which are already being embraced by industry. So there was reasons why the previous ways hadn't gotten traction. FHIR is really changing the nature of our information storage and flows now, and we're certainly embracing that. The next step is to reimagine the orchestration and business logic layer in the middle. So it is fit for purpose, so it's aligned with the FHIR-based information repository at the base level there. So it's managing information at a more granular level than the document paradigm that we're currently working with, and making it fit for purpose for the future state for the MyHealth Record modernisation, but also for any other use case that we might throw at these national infrastructure strategic platforms.
So Ryan, what are you talking about when you talk about national infrastructure? Because Amanda's talked about it, I've talked about it, you're talking about it. What does it actually mean? So
we are talking about the services and the products that are sitting within the agency's control as part of the core infrastructure. We're talking about repositories, we're talking about the centralised authentication and authorisation pieces, and all of the technology that comes together to enable that information flow.
But we're also talking about things like what the Health Identifiers service from Services Australia, National Health Services Directory from Health Direct, and those type of things as well, aren't we?
You're absolutely right, yes. So there is a broader boundary around this. So when we look beyond the scope of the MyHealth Record, there is extra pieces of key technology that will be linked in natively with the Health Information Exchange that will form part of the national infrastructure. All right, so once we've gone through and FHIR enabled the repository, we've reimagined the business logic layer in the middle, we've effectively modernised the MyHealth Record. And what we do is see here is we have a creation of a product, a new modernised product for MyHealth Record on top of these strategic platforms. So that then delivers on the modernisation of MyHealth Record and means that we are having a solid foundation to move on with the implementation of these strategic platforms. Now, once we have this in place, we're not stopping there. We know we need to be able to move on to take the next steps around leveraging these platforms to deliver more capability across the top of them. The first priority I will talk about, which is the first priority for the Health Information Exchange program, is the provider directory, or the directory. Now, what this will be is a harmonised view across all of the provider information sources that exist across the health sector. Whether you're in the red centre or whether you're in the city centre, provider information will be available in a consistent way. Now, we're not talking about duplicating the information here. The information about providers will exist in the places where it's stored and captured to date and maintained, and we will provide a harmonised view across that without having to duplicate it. And the beauty of that is we're linking in real time into those information sources to try to break the burden of maintenance of information in this space.
So Ryan, in a former life, I had to take data from 17 different sources, 17, to bring together the complete view of a clinician. Are you saying that the directory will do all of that for me?
Certainly. So bringing together all of that provider information and taking the burden away from the endpoints who are trying to manually maintain information that shouldn't be maintained there is one of the goals of the Health Information Exchange.
Do you think, Ryan, that an emergency department might be able to use the directory to onboard maybe some locums within 10 minutes?
10 minutes is fast, but that's certainly the goal. So having the information available so you don't have to go and find it is where we can go with the health information being established, Health Information Exchange. So that's the directory. We won't stop there though. So we could apply the same pattern again and again for any sort of capability that the health system needs. In the first instance, we're talking about allied health. So we are looking at two specific initiatives with the allied health piece of work here. Firstly, we're looking to integrate existing allied health solutions where they are available with the MyHealth Record to increase the information flows today. Secondly, and perhaps more excitingly, we're talking about an allied health white label capability that can be used as an electronic system that is already integrated with MyHealth Record, that is already integrated with the Health Information Exchange in those dark spots across the allied health space where there's no current electronic system at the moment, where information is being recorded with paper and pen and where consumers are having to retell their stories again and again as they move through this journey.
And if I was a sole practitioner and didn't want to outlay a lot of money for a clinical information system, I might be able to use something like this?
You certainly would be able to, yes, but I want to be clear here too. We're not trying to compete with industry. This is to try to provide that baseline integrated capability to enable the information flows to progress. Part of what we're doing with the microservices approach for the Health Information Exchange is really enabling innovation, enabling industry to respond with specific targeted information systems that will really suit the specific needs of those particular areas. We're not trying to take away from that. And the approach we're taking is similar to what we've taken with HIPS in the past. So it's not going to be too drastically groundbreaking from an agency perspective, but it will fill those gaps and enable us to continue and connect care across those allied health settings, and indeed any other setting.
And look, it really is important. It's really hard, and I can't emphasise this enough, to interoperate if you're still on paper. And so that is filling a core hole that exists today that we're being told by clinicians and industry and government exists today.
Absolutely, and areas like nurse practitioners, for example, there's a massive gap for information systems in those spaces. There's many pockets across the health sector that are using pen and paper, and this approach can be used to help light up those sections as appropriate. So moving on from there, there's other ideas we can explore. A national harmonised baby book. We know this is a challenge, that physical baby books, different information being stored, and care doesn't always stay contained within your state or territory. So a digital baby book is certainly something we can do in this space. Going on from here, we can move into genomics. Cancer screening, cancer registers. So we can do any sort of register capability. We have the ability to harness information from across the health system and then make it available for research, for analytics, for informing policy changes, etc., that help shape the health system into the future. And lastly, genomics as well too. We've heard a lot from the industry around genomics and the challenges around managing large information sources. And we're looking at what the Health Information Exchange can do to try to help unlock that information for broad usage across the health sector.
So this is not just a My Health Record repository on steroids?
Absolutely not. So what you're hopefully taking away from this is that the FHIR enablement of My Health Record establishes strategic platforms that the agency will use going forward to deliver a broad range of capabilities, not just the My Health Record on FHIR capability.
Well, I'll be very excited not to carry around my baby book anymore.
I'm sure many families, young families, would be very happy with that.
But Brian, it's also important to mention the architecture you and the team have designed is actually set up so that it can search for the national repositories, so those sort of My Health Record or some of the data from Services Australia or Cancer Registry, whatever else. It can also, the architecture is also designed that it can source data from an EMR system in a hospital or from a general practice management system as well. So I think that's really important for everyone to emphasise is we're not talking about national infrastructure being used solely for national infrastructure repositories, but providing a service with the discovery service we've talked about to actually identify where those records are held elsewhere and retrieve them on demand. The joy for us, of course, is how do we deduplicate them at the time, but that's what I have clever people for.
That's absolutely right, Peter. And as we talked about with numerous scenarios already, it's really around accessing the information where it is across the health sector, noting that it's not always going to be in the centre, and making sure wherever it is, it's available to inform care at the right time. Now, we've talked a bit about the strategic platforms and the products that we can build across the top of it here. What I'd like to do next, just briefly, is to delve into a little bit more technical detail around what's happening inside those interoperability patterns when the Health Information Exchange is in action. So before I do, I'll just quickly talk about what a requester is and what an information repository is. A requester in this scenario is any sort of app or EMR, practice management system, that is initiating an electronic request for information from the Health Information Exchange. And the repositories, including the National Infrastructure Repositories, but also including any data source that's available for discovery across the health system, which could be an EMR, as Peter was describing earlier. It will include the provider directories from Health Direct and also from Services Australia. So any information source that's connected is one of the repositories. So we'll take a closer look at the Discovered Information Exchange pattern that we've talked through earlier. Again, the consumers arrived at the ED, they weren't sure around what their medications were, they know they've had medical imaging done. The first step that happens when we delve into this process is that authentication piece. So the health identifiers have been provided as part of the message that's come through. We can verify the provider's health identifier against the directory and know that we're dealing with a real, genuine, authorised provider to be able to access and interact with the health information exchange. The next step is that authorisation piece, where we're looking at the relationship between the provider and the subject of the message, which is a consumer in this case, to determine is it appropriate for information to be shared with this individual at this particular point in time. So we're looking at that relationship, we're looking at any rules that have been put in place by the consumer or any other policy or rules that apply. Following on from this, we then can look at the fun part, the discovery piece, where the Health Information Exchange goes to all the sources it knows about to verify the information is still there, and also discover anything new about the patient that we don't already know. And it gathers the electronic location information for that and packages it up ready to pass back to the initial requester. The last step here is to ensure all of the audit and updates are in place so we can clearly trace and have confidence that there's been appropriate access to the records through this process and expose that where needed. Now, what all this provides is, firstly, indisputable proof of identity that can be used by any system that's connected to the HIE for authentication. It includes that computable authorisation, which basically means any system integrated with the Health Information Exchange can filter out the information that's not appropriate to share with this request, but provide the information that is appropriate. And then lastly, it's those electronic locations that can be used to actually retrieve the information. So this is as technical as I'll get. We'll keep moving on now. So let's zoom back out. Let's take a bit of a look at what happens when we light up the health system with information through the Health Information Exchange.
I know.
Clearly we need more caffeine here today.
All right, so here we're zoomed out and we're having a look at the big picture. And the first place we want to turn the lights on with information through the Health Information Exchange is the provider directories. And we see the emergence of the directory, that centralised, harmonised view across all of the information providers across the network. We see that the same interoperability patterns are being applied here between those provider directories, between the National Health Services Directory, the Standards Australia Directory, and any other directory source, AHPRA. Those same patterns are being used to bring together and expose that information through this process. To provide that harmonised view, to do both provide a source of truth for authentication for all information flowing through the Health Information Exchange, and also to support information flows when you're selecting a referrer to send an information request through to, when you're selecting which provider you want to fill your prescription.
So fundamentally for a health service, that is reducing a huge amount of administrative burden, and the same for a clinician, where there is a single source of truth that's being sourced from all those different directories, presented in a simple, easy to understand and consume way. That means you don't spend days trying to find who to refer a patient to, or who a member of the multidisciplinary care team is, and how to get in contact with them.
Absolutely. So moving on, we'll turn the lights on in another area of the health sector. We'll start turning the lights on for the care settings. And we'll specifically note aged care and disability care here, but really from an aged care perspective, from a care settings perspective, we recognise that the care provided in each of these settings is special and unique, but the information flows and the patterns and the frameworks that enables information to flow in and out of those care settings is consistent. So we can group them all together from an information flow perspective while still recognising they have special and unique processes within them. Whether it's a GP clinic, whether it's a hospital emergency department, whether it's a residential aged care facility, those information flows and the connection types are the same. So making more granular information available to those care settings and embedding that information into their workflows is really where we're going here to really enable that better quality care, better informed care with the right information available at the right time. Now we'll keep moving on. I wanted to specifically call out as well too, we're calling out allied health. Now allied health is another one of those care settings. We just wanted to make special mention of it because we do have particular initiatives in place, being the My Health Record integration with existing providers and that white label capability we talked about earlier, which will again fill in more of those dark spots across the care continuum and ensure the information is flowing and following consumers so we can really deliver on that Tell Us Once promise. All right, next looking out to the diagnostic services. So we've got our medical imaging provider that we talked about earlier. We have our pathology providers. And while I appreciate we already have information coming in from the diagnostic services into the My Health record, this pivot with the Health Information Exchange is really around reimagining the e-requesting paradigm and getting away from that document-based feedback of results into a more granular information flow that can be seamlessly integrated into the clinical experience. Having that information available will make a massive difference in terms of the way people order for diagnostics and the way people use those results.
And Ryan, it's really critical to mention here, I think, that part of the core part of having the consumer at the centre comes through in this particular part, where it actually means that we will avoid unnecessary rebleeding of patients because the blood results weren't available to the clinician who was treating them, or unnecessarily exposing patients to further radiation through imaging because their images are now available wherever needed.
Might this also lead to a national viewer?
A national viewer for diagnostic imaging, look, that is the third phase of the Health Information Exchange, yet to be agreed and funded by government, but fundamentally that's the direction we're going.
Fantastic. All right, I'll keep us moving on our lighting up the health system journey, and we'll look next at pharmacies. So pharmacies, both in the community and both in hospitals, will provide a full picture of medications administration for consumers. So we're really looking at reimagining the e-prescribing paradigm with more granular information, more timely information, and enabling workflows that would suggest a clinician could know whether their consumer has filled their prescription and inform them to maybe have a targeted conversation around why they've stopped taking this medication. Are there side effects? Is there a different medication we can prescribe that would better suit your needs?
And so also, Ryan, on this one, let's think about what it actually means for a consumer, and going back to them for a moment. I'm going to keep dragging us back there every time, I'm sorry, but this actually means that we can put an active script list in a consumer's hand in My Health app that can source all of this data. We'd actually then use it to send a push notification out to a consumer to say, you had this product dispensed 4 weeks ago, it was supposed to provide you with, I don't know, 6 weeks worth of product or less. You might need to go and get it refilled. Like, is that the type of thing we're talking about?
Absolutely. So not only is the HIE going to enable, the Health Information Exchange going to enable the consumer to control the flow of their information, they'll have better controls to manage their own health needs based on the information that's made available. All right, let's move on to light up more sections of the health sector with the population and public health spaces. So with the Health Information Exchange, we have the ability to feed more real-time information out to areas like the Centre for Communicable Disease to better inform intervention actions at a population level and to shape policy and shape the future of the health system where appropriate to really guide the population level health.
Gee, that would have been fantastic to have when we were in COVID.
That would have been amazing, yes. If we had more information flows and if we had the Health Information Exchange in place in that time, we would have been able to move much faster. Although we did move very fast, we would have been in a much better place to brace for impact and prepare for the change.
But Ryan, it's also important to mention it's about here where we go back to where we started, which is we're building a series of foundational services that can be plugged together in different ways. And I think the public and population health side is really where we expose the data at a whole of system level, but also for an individual as well. And so this is really where we look at those technologies that we're not quite sure how they'll work fully in healthcare yet. We haven't all worked through some of the technical and ethical and legal issues such as sort of quantum computing and artificial intelligence that could actually do things at a population level, but also provide real-time support for clinicians with clinical decision support to feed back in at real time. So this really, to me, is a core part of what we're doing.
Absolutely, yeah. The possibilities in this space are very exciting, and I'm sure we'll no doubt have plenty of excited people wanting to delve into this space very soon. All right, now let's move on to lighting up the consumer information sources, last but not least. So here we're talking about regulated medical devices in the consumer setting, wearable technology, and any other source of information from the consumer. Now we recognise that there is a vast amount of potential information that can come from this source, and the agency are actively working with the standards organisations, with looking at the frameworks, etc., to figure out how we can make sure that the information complements care delivery rather than overwhelming the care team with a crazy amount of information that comes through. And there's some exciting examples that we'll no doubt explore into the future in this space.
Well, I mean, Peter gave us an exciting example earlier with his 1 lead ECG on his Apple Watch.
Certainly did. So that's certainly an example of where we can see that wearable technology and any sort of consumer-sourced information really informing and improving care outcomes. Okay, so now that we've lit up the entire health sector with information via the Health Information Exchange, I think it's time for us to reflect back on what it is we're trying to do in this space. So we're really looking at what the Health Information Exchange is. And again, it's not just building content in the national infrastructure. It's about getting that consistent authentication and authorisation and discovery process happening across the systems. It's about bringing together all of the systems and all of the silos so that we can all share that information and empower the clinical teams to deliver the best possible care, empower the industry to do innovative solutions that will enable that care to be delivered as effectively as possible. It really is about delivering better outcomes through secure information sharing across the Health Information Exchange.
And look, the benefits and overall value will be driven by all of us. We can't do it alone, and the reason why you're all hopefully in the room here today is to work out how you can work with us to deliver this vision. So what I would say is now's the time to start thinking about what innovation and services and capability you can bring to this transformation. And with that, I'm going to say thank you, and we'll hand over to Joanne, who will be shortly coming to explain exactly how you get involved in the next steps.
Thank you, Peter, Ryan and Nicole. Thank you very, very much. So I'm now going to pass over to Joanne Greenfield, our Chief Operating Officer, to actually talk you through how that vision lends itself to the annual procurement plan that was published recently and how we're going to work through those procurements going forward.
Thanks, Paul, and thanks to my colleagues there for giving that inspiring overview of the technical capabilities that we're developing. So the activities you've heard about today are transformative. They're transformative for the health sector, for consumers, for partners and our stakeholders, but also for the agency itself. There's going to be a significant interconnected body of work. As the agency, we're developing our detailed procurement plans right now, and we're considering within that context the national government's strategic commissioning framework and the changes to the Commonwealth procurement rules that were issued on the 1st of July. So before we discuss the planned procurements that we're putting in place, I want to first mention that we're not only working on the what, we're working on how will we deliver this. And part of that is working internally to ensure we get the optimal operating model for the agency. We're looking at the most effective mix of in-house design and delivery capability combined with outsourced approaches. This includes strengthening our in-house system integration capability. This is a complex exercise with many considerations, not but least the need for modern, clinically safe and consumer-focused digital health products and services, at the same time delivering on the government's strategic commissioning framework and ensuring value for money for the community. We recently released an open tender, and that's open until the end of the month, to look for partners with lived experience of going on this journey. To support the agency to identify and develop the required technical capability and operating models to deliver this agenda. In terms of the planned procurements and the way we will deliver and implement what you've just heard about, the agency has already published an updated annual procurement plan at the end of May. That has 4 planned procurements outlined at the current time. The first you heard about from my colleagues in a lot of detail, My Health Record, Fast Healthcare Interoperability Resources. This is My Health Record on FHIR, looking to support the shift to FHIR-based data-driven systems and connections, and we'll be issuing that procurement in the first quarter of this year. The next 2 on the APP are offerings on allied health. So allied health connections to My Health Record products or services. This is to help the sector engage with clinical information held by consumers in My Health Record. The second allied health item on the APP will be software for allied health clinical information connections to My Health Record. This will likely be through an industry offer, again, the first quarter. The final item on the current APP is the operational management product enhancement services for My Health Record Solution. You may have known that previously as the NEO, or the National Infrastructure Operator contract. The name's changed to reflect this is different. As you heard from my colleagues, the approach going forward is very different to the current infrastructure. And that will be likely third quarter 24-25. As our planning evolves, and as you saw, as the next stages evolve, there'll be additional procurements that may emerge, and we'll update the APP as that happens. Our aim through all of this process is to be open, transparent, and competitive. We're committed to managing open, transparent processes through our procurement mechanisms, and we'll be applying the open first principle. That means when we consider our procurements, we'll be applying the Commonwealth procurement rules, including those changes that were issued on the 1st of July. We'll also be looking at other connected government policies that influence procurement. But at the same time, we're keen to tap into the IT and the health sector expertise. We're keen to draw into the expertise to draw out innovations. Where appropriate, the agency will engage with portfolio partners and potential external partners to seek inputs on the possible solutions and services we need to deliver. This means we may undertake further industry engagement sessions, and as part of individual procurement activities, we might engage in multi-staged approaches so we can draw on that innovation from the sector. It's critical that we uphold integrity throughout these processes, and through our probity principles is how we will get the best outcome, not only for the sector, but for our consumers. We'll be looking at these open and transparent processes, not only to engage innovation, but also to make sure we get the best products available. I encourage all interested parties to consult the recently issued Commonwealth Supplier Code of Conduct. That will be setting the baseline and the standards for the expected from our suppliers, including the ethical behaviour baselines. How can you stay connected to us and keep with us on this journey? It's really important that you consider, if you're not already registered with AusTender. It is free to register, and you'll get automatic updates then as we update those procurement approaches and update that procurement plan. I also encourage you all, if you're not already linked into us, on our social media channels, including LinkedIn. We'll be publishing more events like this, the industry engagement sessions when they're about to happen, as well as keep a monitor on the agency website, because we'll be updating our plans and procedures on there as well. I want to really thank you for your time today. It's so exciting to see such positive, high-level attendance here today. I think it bodes us well for the exciting future that we've got. I'll hand back to Paul now.
Thank you, Joanne. Another final plug for Slido. If you haven't asked your question, please get them in. Now I'm going to invite Dr. Steve Hambleton, our Specialist Clinical Advisor, to the stage, who's going to facilitate a Q&A session. And whilst he's coming to the stage, I might ask my colleagues to join us up here as well.
Thank you, everyone. Thank you for your attendance today. And I've got to say that we've got well over 100 questions, and you'll be happy to know if we answer them, you'll be here till 3 o'clock. Having said that, we're going to make sure we're answering all the questions, and we'll in due course you'll get those answers. So thank you for joining me on the stage, for everyone up here. Thanks, Paul, for your work up to this point, and thank you for the questions on Slido. Look, who have we got here? We've got Amanda Cattermole, our CEO, Peter O'Halloran, our Chief Digital Officer, you've heard of already, Joanne Greenfield, who just spoke, Paul Creech, who was our MC, as well as our Chief Program Officer, and someone who you've not met already this morning, Julian Martin, who's our Acting Chief Technical Officer. He's doing that work at the moment, but his day job is actually, he's responsible for technology planning and delivery. No pressure. Yeah. Okay, so look, it's a difficult format, and so apologies to those in the wings who may not be able to get a good view, but remember we're recording today and you'll be able to watch it back again, and Look, the first question I note would probably go to Amanda. So over to you, Amanda. Thank you for the presentations this morning, says the question. I note the ambition, however, that we've been at this for 15 years now. Why will this time be any different?
Thank you, Steve. Thanks, everyone. It is a good question. And I think, look, there are some really important differences, but there's also some kind of continuity and evolution that I think is worth talking about as well. So I think one of the main differences is that it is Australian healthcare consumers who are really driving this agenda. And we saw that in the Strengthening Medicare Task Force. And in fact, it's really the basis on which the Sharing by Default agenda was crafted. It was crafted by a response to give life to that changed consumer expectation that information will be shared, it will be available in people's hands, it will be there at the point of care. And so I think that is one significant difference, and we've seen that over the last few years, and the momentum is still going. And I think it gives life to the second difference, which is the bringing together of that expectation and a health policy platform and digital enablement helping to drive that policy change. And I think that those things together are also really different. The third thing is we see so much momentum in the same direction. We see it from governments together through the Intergovernmental Agreement on Digital Health. We see it right across the healthcare sector. We see it in things like the Council for Connected Care and leaders coming together to say we want to help set the standards, we want to help articulate the vision, and we want to go forward. And I think those things together and the interconnected nature of what is happening in relation to them is really driving change in a way we haven't seen before. But to the extent that this journey, like all journeys like this, did not start yesterday, it's absolutely vital to acknowledge the extraordinary effort that's gone on over the last 10, 15 years. Many of you in the room, many others you know, who started having this conversation, who started raising this when we didn't have all of these things that we have now, who helped set the foundations on which we now grow and we grab the moment that we've got. So it's like all such things, this sort of change process does not happen overnight. And I think while we enjoy a remarkable set of circumstances, we also absolutely should acknowledge the remarkable effort on whose shoulders these changes actually lie. And I think those two things together bring us to where we are today.
Thank you, Amanda. And Jeremy Nibbs, thank you for your question. If you could only pick 5 initiatives from your very long list on the delivery roadmap, what would they be and what order of priority would you give them and why? Probably Peter. Yeah, look, and I would argue that my wife is incorrect. I can actually multitask, and some men can, despite all evidence to the contrary. Look, fundamentally, I think we don't have time to only do 5 initiatives. We actually have to do them all. And what I'd say is if you look at all the various plans, if you look at the digital health strategy, if you look at the interoperability plan, look at the HI roadmap, and if you also look at the annual procurement plan, that sets out our very clear agenda for what those top 5 priorities are and the direction we're going. The vision we laid out this morning, realistically for all of that to come together is probably a 10-year journey to get all the things of quantum and AI and all of those things coming together. But those foundational building blocks, which is work by all clinicians and by Services Australia and everyone else around the health identifiers, though that work that is going through the annual procurement plan that's talking about we're going out for MHR on fire and we've got allied health and we're going out for the replacement contracts for all those things. Those are those top priorities. The reason why those are our top priorities are those are the things that have to be done now that enable everything else. So we've crafted them and we're doing as many as we can in parallel. But I think we all recognise there's probably 1,000 things that need to be done. I'd love to do 1,000 in a year, and we all know that would implode spectacularly. We're pacing ourselves, so we're doing the immediate ones that need to be done now that enable the future things, but also actually give consumers and clinicians some sense of progress and actually that acknowledgement that they've had these problems in the past, and we're starting to solve those problems today. Yeah, thanks, Peter. And you'll know that if you keep voting, you can push these up the list. And the next one's a very popular question from Jessica White. How will the Digital Health Agency ensure that the work streams coming through the Department of Health and Aged Care and the agency are aligned and not competing, and that they're implementing via co-design? That might be... Yep, thanks, Paul.
I'll take that, Steve. And thank you, Jessica, for the question. Unless it is a really, really good question. And it's an area that we've got to do better on. We freely acknowledge it. I think there's a couple of things in this. The last 12 to 18 months, we have put a lot of effort into putting out the frameworks, whether it be the National Digital Health Strategy, the Interoperability Plan, HO Roadmap. We're trying to give as much foresight and vision as to what's coming down the path as we possibly can. The second thing, and I think the thing that's probably far more important, you will have heard today from Peter, Ryan and Nicole, a lot of what we want to do going forward is actually about leveraging other parts of the system, not about building things ourselves in isolation. The sheer fact of taking that approach is going to mean that we need to work more closely with those other parts of the system to make sure that we're in alignment. I think that it will continue to be a challenge for us, and we'll continue to work with you guys as a sector to try and improve. We make that solemn promise, but we do think we've got a good couple of foundational changes or pivots in place that will help us to achieve that going forward. And the other thing that I think we have as an agency really started to hit our straps on the last 12 to 18 months is the degree of transparency coming out of the agency. What we're doing, how we're doing it, I think all helps to that end.
And there was also a part in there about about co-design. Sorry, I'm not reading the two. Maybe I can't do two things at once. Talk about the co-design. Look, I think that's an area the agency is actually really good at. Is actually doing that detailed design in collaboration with consumers, their carers, and clinicians. And that will drive everything we've done. It has over the last couple of years, and will be used ever more and more as we go forward. I think that co-design is essential to ensure that we actually truly meet the needs rather than the needs that we perceive. And so what I would say is we will continue that co-design approach. We'll continue to improve and increase upon it. But it's actually one of the things I think the Digital Health Agency actually is probably groundbreaking in how we do it and how successful it is, and we'll continue to evolve it.
All right, thank you very much. And I had a comment too, but I'll probably save mine up till the end. But Robert Volk, thanks for the question. Can you describe the distinctions and overlaps you foresee between the My Health Record Fire modernisation and the HIE program? Maybe Peter again.
Look, there are absolute overlaps, and we're deliberately designing to be overlapping. There is no reason why we go and build two different authentication services when one would do perfectly well, and we use it for multiple purposes. So from a technical perspective with those services, there's complete overlap. From the repository perspective, it's a very different answer, and we'll maintain that segregation. But I suppose I look at it this way and say My Health Record was always designed to be, and will continue to be, a summary of key information of someone's critical health information, that if everything else goes down in the country, there is core information in the centre that can be provided and made available to clinicians to provide safe, high-quality care at an immediate point in time. What the Health Information Exchange will do is add colour and movement to that and bring together the full range of data to help the sharing of information from one provider context to another. And so think of the MHR as a summary and the core. HIE is the colour and movement and the full record and all those information flows that wraps around it.
Thank you. Thanks for filling that out. I think that's very good. Now we've got another question at the top there. How will the Digital Health Agency work with clinicians to ensure that the changes are workable to ensure uptake and engagement by those using the systems? Maybe that's Paul.
I'm happy to take it. Again, a really good question. They all are. Following Peter a little bit too, I think we do have a reasonably good track record as far as working with the sector goes, especially the clinical peaks and the clinical groups. We are going to have to engage with them more. This is a significant cultural change. This is significant transformation that we're proposing here, and the way that we do that. So we will use the channels that we have available to us already, and they are used now, and they are significant. We will grow those channels to try and make sure we've got that buy-in. A good example is the work that's being done with Sparked on Fire at the moment. It is a community that have pulled together to drive that piece of work, and there is a whole heap of clinicians really interested in that. So building on that kind of community approach. Peter touched on it during the presentation today, talking about the Council of Connected Care. Very much a focus on not just consumers but health professionals in that group as well. So how do we include them in a co-design way? How do we include them in everything we do to make sure that they understand not just the process, the intent and the outcome, and they can add value to that is our challenge. But it is something that I think we have stepped up the last little while, and we'll continue to step up going forward.
Thank you very much. And as you can see, if you keep voting things up, they'll pop to the top. So Emma Hossack, thanks for the question. What about the consolidated real-time contextual view? Will parties just have to string the various retrievals to make sense of them? And that presumes 100% uptime.
Look, this is a challenging one, and I think is probably the one that's caused the most debate inside the agency of exactly how we move down this path, because there are pros and cons no matter which way you go. The consolidated view will absolutely be there and it'll be contextual. Parties won't have to string the various retrievals to make sense of them. The idea is that the information is displayed in context and the specifications will talk about how that information is synthesised. The challenge is fundamentally then, how do we make sure that that view is actually relevant for that clinician? And this is potentially where AI in the future could actually help provide synthetic data views that perhaps takes the stuff we did with My Health Record for Medicine views some years ago, but it really puts it on steroids that says, you're looking at a patient in this context, I can show you the most relevant information up front and flag it first. So that's actually, I think, in the future where I see a role for AI. Secondly, we then go to that discussion around how fast can you retrieve it? Does it require someone else to have a high-speed internet connection, all that type of stuff from a third-party system to then populate into your system? If I talk to people internationally, this is actually one of the biggest challenges. And people will tell me routinely in some places it takes 5 to 7 minutes to retrieve the information. Others will say, if it's one very big provider in the US, that they break the QHINs once a week, every Monday morning, when they try and update every patient they've ever seen through the VA. And so there's a real challenge. It actually comes to the crux of the problem of, do we keep it all in the centre, or do we let distributed versions of some of the data exist? And I think the answer is we're designing that we can do both. I think that's actually a decision that we'll all need to get to, exactly where does that pendulum swing, because it's never going to be all centralised, it's never going to be all decentralised, and neither it should be either of those. It's what information is how far towards one or the other. And I would say the days of GP practices turning off their servers every night to save electricity probably have to come to an end. That is not the best way we do these things moving forward, and that is the reality, though, that we live today. And so we need to look at those type of things to say, well, maybe more information from people who turn it off every night should be stored centrally versus, I don't know, a big EMR system from a state where we might go, odds are they're probably going to keep it up. So I don't have a straight answer, Emma, but it is a real challenge.
I felt sure you were going to work the quantum computer word in there again. But look, there's another question. Please tell us about the current data governance approach, responsibilities and progress for the Exchange initiative. Who'd like to take that one?
I'll take that one, Dr. H. Thank you very much for the question. That's a big question for a number of reasons, and you could interpret that a number of different ways. I'm going to lift it right up to the top level because I think actually one of the best things about the existing national infrastructure or the My Health Record system isn't the technology, it is the legislative framework that provides the consent arrangements for it. It is actually extremely powerful and it works quite well. So at the highest level, one of the things Peter's team's just walked you through, the vision for the future, it really does hinge on using that consent model, that legislative basis, as a data governance framework for the information flow. Of course, we want to evolve that over time. We're working with the department, our colleagues in the department, on review of the health identifier legislation. We're working with them on a review of the My Health Records Act itself, and the want will be to evolve that over time. But it is a powerful consent-based model and it provides very good data governance structure that we want to operate in. And actually part of the design process for HIE is how do we best use that legislative framework that provides that data governance for us. Within that, and I won't go into too much detail because you could talk about it a lot, within that there is a stack of data governance within the system itself that we draw on, that we use all the time. And for those of you who don't know, there's also work happening within the department that we're supporting at the moment in parallel with how might we use national infrastructure and the data within national infrastructure going forward for public health and policy research purposes. Building a community governance model, building the social licence required to be able to use it, but that is work in play as well. It's not a short-term thing, it's not going to happen tomorrow, but we are putting in place the framework over a period of time that will enable that going forward too.
Thank you very much. I'm just hoping there was a question for Julian, maybe even Joanne, but are you already set on the technology and the software and you will use to deliver this vision, or are you open to procuring new tools? That'll be Joanne or Julian.
Yeah, I'll start and then I think Julian might add to it. So, no to the first part. We're not set on the technology and the software, and yes, we're open to procuring new tools. So the annual procurement plan sets out the initial procurements that will evolve, and we will add other procurements to that as the planning evolves. The reason we follow the underpinning probity principles of the Commonwealth procurement rules is about competition and getting the best outcome. Using a multi-staged approach, as I flagged earlier, for some of the procurements will allow us to tap into the expertise of the IT sector and the health sector, looking for those new tools or new solutions before we then finalise procurement. So yes, we're absolutely open door.
And I'll just go on a little bit from that. If you look at what Peter, Ryan and Nicole were saying, it was all about standards, consumers, providers. There was no talk of the actual technology. So it's just reinforcement of the fact that we're very open to looking at different technologies moving forward.
Look, and we've got some big providers in the room. I see them here, but the small providers, the innovative, nimble ones were...
Absolutely. And you'll also notice recently government policy came out encouraging the use of small to medium. So that'll be part of what we have to comply with as part of the Commonwealth procurement rules. So yes, definitely encourage those small to medium people to put their hand up.
Thank you very much. Will the Health Information Exchange own and maintain a universal semantic layer that makes the source of data analytics ready? That sounds like a technical question.
I can't imagine why Paul didn't want to answer this one. Look, the short answer is yes. Exactly how we do it and how far down that goes is yet to be debated. But if you go back about 50 slides ago, you'll see the one where we talk about the standards and what we were doing. You'll see there was a strong approach to a lot of the clinical terminology, ontology, sort of the SNOMED CT side. Also, there was a reference, and we didn't really talk about it, to open air and let's talk about OMOP and those type of things. That is absolutely the direction we are going, because we recognise that the HIE is both transactional for a particular point in time, but also longer term is about how do we actually use that data for other purposes. So the short answer to this is yes. Let's probably not spend the next 35 minutes talking about it in detail because it'll bore even me, but yes is the answer.
Look, thank you very much. What are the most prominent KPIs and metrics the agency will use to assess itself and its digital health POW? Sam Bartoni asked the question. Maybe Amanda, maybe Paul?
I'm happy to go first, boss, and then you can fix it for me. Again, a really good question, and it's something that we have, I suppose, been working on for a while now within the agency. And one of the things that we talk about quite a bit in relation to KPIs, especially in the new world as we push through, is access to information, the availability of the information. So it's not just about people being able to access their own information, which we do have good data on, and you'll see some of the reports that we've put out recently in relation to usage by consumers. It's heading north and growing fast, and it's been really good to see. But we also look at things like cross-shared views. So how many individuals out there who have got multiple providers that have looked at their record, or views of information that was uploaded by one provider and viewed by another. Those kind of metrics are things that we use reasonably regularly and will continue to. Plus, we also want to grow that out. And build more what I would call qualitative measures into, not just quantitative.
Yeah, that's perhaps the only thing I would have added is I think this is a great question, because as we go on this evolution, we want to be able to evolve and deepen the metrics and have system-wide metrics where we can measure, more fully and deeply what is the impact on the system overall. And there's quite a body of work at the moment going on around the kind of mixed methods, research models and measurement models that we might bring to bear as we look more deeply at interoperability, for example. What does a measurement look like in that context? And also as we consider how you measure the value from a more connected healthcare system. So there's more to do here, is my view. I think we've made some really good inroads, but as this work evolves, so should that measurement work, and that's exactly where we are at the moment.
Thank you very much. And I keep wanting to ask the second question, but Emma and her friends have voted it up, have got to the top of the list. And it's a good question. Filling gaps is good. How's the provision of a base system not competitive with industry? Will there be a request for tender for a system, or will it be in-house by the agency?
I'll start, and then I think Peter might add. So we did talk earlier about we have got an RFT in the market at the moment, and that's really looking at the operating model for the agency. We need to make sure we've got the capabilities internally to be a better customer, as well as decide what parts of the system we design or deliver in-house versus what we procure externally. But it doesn't mean that we're not got a mixed model. We definitely will be in the market for procurement, as well as building things like the system integration function internally.
And look, the other thing I'd add is the agency has historically stepped in when there's been a gap that has not been filled by others, and in some cases has not been filled by others for many years. And we'll step in, provide a system or a service. Often that's then actually sourced where the agency will then go and run a procurement to commission someone from industry to build it. And HIPS is a good example. We've done it with CVIT before. Like, there have been other things where we'll go in, we'll do it, and when there's no longer a need for it, it'll actually be decommissioned. So it's not as though we're saying we'll build something and keep it for the next 30 years. We'll fill a gap where there is a gap that needs to be filled, and where it doesn't need to be filled, we can step back out of that space.
Thank you. All right, I get to answer my favourite question. It's good to see the agency now has ongoing tenure. And I'll just pause and say that is extraordinary. And I'll talk about my own history coming back in a moment. But we've got ongoing tenure that gives industry confidence. It gives everyone confidence we're going to be around for the future. But to share information appropriately, how to get an updated health service directory of providers, how are we going to do that?
Look, I mean, this comes back to, and Sandra, as you know, I could talk for hours on this particular, well, on any topic, but particularly this one. There is a massive challenge out there at the moment for everyone around the information about the services and the individual providers that are providing those services across the country. And I said before in a previous role, 17 different data sources for a single individual clinician. And that was in one provider organisation, and let's be honest, across the country, everyone else was doing the same thing. The process will be, and we're doing the architecture now, we've been consulting with jurisdictions, we've been consulting with private providers and the like, is we are looking at sourcing the data from multiple sources, making it available. It will in essence be, I suppose, a federation. The directory will largely federate most of those existing sources, so the system of record will still be AHPRA if it's around someone's sort of clinical sort of practice scope, Services Australia if it's around some of the sort of provider, prescriber numbers, those type of things. We'll source that information. It'll be exposed to health service providers and to individual clinicians through a web interface that's appropriately secured, but also through APIs. So they can actually have a machine-to-machine interface to update it, query it in real time and so forth, and actually attach, for example, the fact that Sandra Cook works for this particular health service, so that automatically then means some of that authorisation, authentication stuff can flow. For a consumer, it'll also be exposed to them as well, in that we'll be exposing that data to consumers, and the services part is probably more relevant for many consumers. But the provider part is still relevant when you're looking at an individual clinician. Where are they? What are their contact details? What are the exact scope, any limitations of their scope of practice and so forth? That'll absolutely be made available to clinicians as well, to consumers. And yes, Marin, consumers have the right to choose who has access to their data under the current legislation now.
Well, you can see that the questions have been disappearing as we've been watching, and that's because we did promise to get you out on time at 12 o'clock, so thank you very much for those questions. Have we sufficiently answered Marin's question there, do you think, Peter? I think so. We are going to expose it to consumers. Consumers will have the ability to actually influence where the information goes. As you know, they've got enormous controls now, and that's deliberate and on purpose, and some consumers do benefit from those controls. But look, thank you everyone. Thank you for the panel members for coming up to being available to answer the questions. That's the toughest part of the day, answering the questions on the fly, but often they're the important ones to the audience, so we do thank you for those answers. Now, we did say earlier that there were hundreds, I'm not sure there are hundreds, but there's well over 100 questions. We're going to attempt to answer all of those and distribute the information in various ways. And they may not all come out in a list, but we may have to aggregate a few, so you may not see the exact words, but we'll try and get those information out to you. And those extra insights, I think, are just round out the morning. Look, I just think I'd like to say a few words as we sort of approach the close of the day, and probably speaking on behalf of some of us who've been around digital transformation for now a long time, and more than a decade for myself. And I was actually part of the PCEHR review, those that remember the PCEHR in the room, the Royal Review, and we made certain recommendations that made certain changes. And I ended up being the chairman of NETA, the National eHealth Transition Authority, and our job was to set up the beginning of some of these standards. And we handed over the work to the agency. And I've been involved with the agency along the way as well, when I'm very privileged and grateful to be there for that journey. But I've also been part of the health reform journey. I was on the Medicare Benefit Schedule Review, I was on the Strengthening Medicare Task Force, I'm now on the Implementation Oversight Committee. We heard about some of the recommendations from that committee, sharing by default. You know, my conclusion listening to today is the vision is becoming a reality. This is what we were hoping for. And we're not there yet. We've got work to be done. But the environment starts to feel right. And I look at the environment. We've invited you here today to talk about the Australian digital health infrastructure, and the advertisement says a healthier future. It doesn't show you a computer. It doesn't show you the stuff that Peter was talking about. It talks about people. You know, Amanda opened the day today talking about safety, security, trust, and health outcomes. She didn't say we're going to build a whole lot of stuff and that's what we're going to build. It was about the outcomes. It was about the impact for our people, for Australians. You know, Minister Butler, we saw the quote earlier, digital health is the single greatest opportunity to transform healthcare. It's not the destination. It's going to help healthcare improve. We must move to a wellness system as well as a healthcare system in this country, or we won't progress. We've already heard about the outcomes in the ACT. Decreased duplication, decreased irradiation of individuals, increased efficiency in emergency departments. The Productivity Commission's dipped its toe in and told us there are billions on offer for savings. So it's a time for investment. That's what it talks to me about. The policy settings are aligned. I've never seen the agency and the government work so closely as I am at the moment with the ministers and with the jurisdictions who are also aligned. You know, the Australian public are calling for this, as we heard. They're encouraging their providers to get on board. My family certainly is, I can tell you. We heard from Peter O'Halloran that this is about improvements for all clinicians, not just people in the hospitals where the big money is, for the GPs, for the allied health professionals, for pharmacy, for nursing, for paramedics. Because hell, I want the paramedic to know about me if he's on the way to my place. We want the information to be embedded in the clinical workflow, and that's a big challenge for those sitting before me. You can get it now. We just need to put it in the right place. We're not asking our clinicians to go to a second or third location or 17 locations to put the information. Let's get it into the clinical workflow. We're partnering with industry was the message I heard. We're not competing with industry, and we tried to clarify that for you in one of the questions. We're supporting scalability, and I'd like that word. You know, if you build something, if you're a small provider and you've fixed the problem for a region, you should be able to make it national. But we also heard maybe you should be able to make it international. And if you've got products overseas, maybe they're relevant to us with some minor tweaking. That's what we need to be digital leaders internationally. And we're moving from a focus on my health record, which everyone likes to criticise, to that health information exchange, to flesh it out, to put the rest of the information on the table, to get that distributed data, access to that distributed data near real time. But let's use using agreed standards and modern technology. In other words, that's our new national IT infrastructure. And all this is underpinned by good clinical governance. And at the end of the day, that's about quality, safety, and continuous improvement. Now, today's session has been recorded, and the recording will be available on the digitalhealth.gov.au later this week, along with the slides. So all of those slides you saw are available. And ladies and gentlemen, that brings our time together to a close. Thank you for joining us this morning. I hope you found the session informative, and we look forward to the next chapter in the digital health journey for all Australians. Thanks, everyone.